Hi everyone, thanks for attending the session on the final rule. And we've expanded it, as you see by the title, CMS and ONC. And I always feel like I like to break the code on this because sometimes there are people who haven't been throwing these initials around and they have no clue what it really means. So in Washington, there are two different departments. One, the Center for Medicare and Medicaid Services, CMS, and the other is the Office of the National Coordinator for Health Information Technology. They're both part of Health and Human Services. The ONC part is, at least the way I simplify it in my mind, is the technology arm for meaningful use. So ONC is the group that actually does the certification of the EHRs. That's their mission. So when the stimulus bill was passed in 2009, ONC got some more horsepower, I guess I would say. They were started in 2004 by executive order by George W. Bush. And then with the stimulus bill in 2009, then the legislature empowered them as a full-blown, I guess I would say, bureaucracy. So at that point, the thinking was CMS would handle the operational side. What does it take to use electronic health technology in a meaningful way? And ONC would make sure that the technology you're using has the functionality so that you can perform the things you need to do. And that's true today. So that partnership between those two arms continues to today. So the way the legislation works, there's something called a final rule, and that appears periodically where new requirements, new specifications are determined. It starts with a proposed final rule where there's comments and input and ends with the final rule. Both ONC and CMS came out with proposed rules at about the same time this spring, and both of them adopted the final rule on the same date, October 16th. So what it's really doing is trying to coordinate the technology side with the operational side. So today we're going to talk about both of those elements, the CMS side, which is what I'll focus on, and Joe is going to address the issues that have come about because of the ONC final rule, which outlines technology that needs to be adopted in the next couple of years. Disclaimer, which says we're going to do the best we can to be accurate. Anything that isn't accurate is not out of any malicious intent. MeHI, as you heard from Lawrence this morning, this is our reason for being. I would just add one thing to what Lawrence said, and that is we're a work in progress. So MeHI is continually evolving and looking at what are the next challenges that the provider community faces in terms of the adoption and use of health information technology, and what role can we play to help everyone navigate those waters. So we are rather unique nationally in that the legislature created MeHI to facilitate success across the Commonwealth. So that's a tip of the hat to the political process, which many of us have questions about how it's working, but in this particular case, they really, in my judgment, really looked at you need another piece beyond Medicare or Medicaid incentive programs to help people understand what's going on and be successful. The second one, performance-based reimbursement, which several sessions are going to be addressing that issue. For those of you, and I always try to look at this, we have a spectrum of people who are masters and experts at all of this, and then we have people who just got reassigned and they said, hey, why don't you go to this session? You're now in charge of meaningful use. So I try to be somewhat balanced in the approach. So the performance-based reimbursement is a national effort, and Massachusetts is also, at the forefront of that, moving away from claims-based reimbursement. So it's driven largely by the technology. So you can capture performance in terms of quality measures and generate metrics, and then that will translate into payment amounts. So it's an attempt to move away from transactions. In other words, the more folks you admit to the hospital, the more money you make, but yet that's a very costly way to deliver health care versus, through a primary care provider. Meaningful use came about actually a little bit before the stimulus bill. 2008, there was legislation introduced in Washington. And the idea there is, how do you marriage the health information technology and the workflow, the delivery of care? How do you kind of weave that in? Because there was criticism, and actually there still is criticism, that people looked at the health information technology as doing the same thing you were doing on paper, but now storing it in a computer. So that is a challenge to say, well, really we're looking at a different way of doing healthcare, which is for some people scary, for other people kind of exciting. So that's a key element, is this idea of meaningful use is the marriage of what you're doing clinically and how you're leveraging the power of the health information technology. The original format was to do 3 stages incrementally moving forward. One of the challenges is, like right now, the stage 3 requirements have just come out, so there isn't much advance warning in terms of how these various stages are going to play out. So I'll dive into this a little bit. How many of you attended our webinars on the modifications? Anybody? Okay, not too many. Okay, good. So I will talk really fast. One of the things about the final rule, there were actually 3 proposed final rules. One was a stage 3 final rule, one was the ONC final rule for the technology, and a third one was modifications. So CMS said, you know what, let's try to simplify the transition from where we are to stage 3. Let's build a bridge to ease that transition. So we were expecting to have 3 final rules. CMS instead said, we'll combine the modifications and stage 3 all in one. So the modifications are enforced between now and 2017. As I mentioned, the final rule was published in the Federal Register on the 16th, becomes effective December 15th. It's sort of like a Back to the Future time warp, in that this is actually covers 2015, even though it's going to be finalized 15 days before the end of the year. It's kind of a magical approach to legislation. So, which I think a lot of people are now used to with CMS. So here's the deal. Between now and 2018, the current EHRUs is called a 2014 edition. And by 2018, everyone will need to upgrade to something called the 2015 edition. So begin the conversation with your vendors about what does that mean, what does it look like, how do I make that transition. In the process, stage 3, you can attest to stage 3 as early as 2017 if you have the new EHR. And one of the benefits of attesting stage 3 in 2017 is you have a 90-day reporting period. If you don't do stage 3, then you'd be required to have a 365-day reporting period. Another thing CMS has done, they've changed the terminology so that you no longer have core measures and menu measures. That's out. So there's just measures, or objectives. So you have the objectives, and you have 10 objectives. It's called modified stage 2, which apply to everybody, even if you were scheduled for stage 1. However, the measure, and the difference between the two, the objective is the goal, and the measure is what you have to do to demonstrate you've achieved that objective. There are some exceptions for those who are scheduled for stage 1. So even though it sounds like it's a step up, everyone's going to be doing stage 2 in terms of what you actually have to show for the measure. If you were scheduled for stage 1, the criteria is pretty much identical to what it was under stage 1. So it isn't as terrifying as it might first appear. Reporting periods, everybody for 2015 does a 90-day reporting period. And interestingly, this is one of those back to the future things. You could pick January, February, March of 2015 for your 90-day reporting period, even though these rules haven't come out until now. So it's allowed. Everybody in 2015 has a 90-day reporting period. Anybody who's starting meaningful use for the first time gets a 90-day reporting period. And in 2017, if you install the new version of the EHR, you can then attest for 90 days for stage 3. 2018, everybody has to have the new EHR installed, up and running on January 1st, and attest for a 365-day reporting period for stage 3 in 2018. So you can see it's like a converging of all the objectives, all the measures, all the different providers are going to be marching arm in arm as of January 1st, 2018. A number of objectives are being removed, and a number of people have complained about this because they've said these are the easy ones. Why are you taking these away? We get no endorphins. We feel real charged because we're successful at these, and you're taking them away. So you don't attest to these anymore. These are the 10 that remain. I'll just keep rolling here because I don't have too much time. A couple of changes, the patient electronic access. If you're doing stage 2, you just have to have one person log on. It used to be 5%, so it's one person. And the point there is the functionality has to be shown. You just have to show that the EHR is capable of allowing people to log on. The secure messaging, one of the interesting twists, it used to be that the patient had to send the message. Now the tables are turned. The message has to come from the provider. So that's kind of an interesting. Ultimately, of course, the goal is it goes in both directions. And the public health reporting has been simplified to some extent, and it's one objective. And if you're scheduled for stage 1, you just have to meet one of these. On stage 3, all of that, remember, that was the modifications. Let's see, why don't I get, so there's a couple of key elements. Coordination of care through patient engagement. API is one of those amazing terms. Application programming interface, which to me translates to electronic gadgets. So what this is allowing is the potential of communicating through a lot of different electronic devices, rather than just the patient portal, which is locked into, computer system. So you can see where this is going. It's really moving in the direction of more flexibility, more adaptability in terms of technology that people are actually using, and how can that become part of the healthcare process. Health information exchange, this is what Lawrence was talking about in terms of more communication between providers and in terms of the sharing of information in a secure way, an electronic way. And this is moving towards stage 3. It's increasing the percentage of transactions that have to be done electronically. Public health reporting, you have to do 3 measures. Again, the idea here is that there's more interaction with the public health people. So I'd like to turn it over to Joe, who will focus on that technology piece. Remember I said there's CMS and ONC, and the ONC handles the technology requirements. And this will give you some insight into how to communicate successfully with your vendors.
Hi, thank you. I'm Joe Kynoch. Thank you, Al, for setting that up. I'm a MeHI project manager, and I'm going to talk a bit briefly about ONC, what they are, who they are, what they do, and how it might affect you as we go along, especially as it comes to meaningful use stage 3. So ONC stands for the Office of the National Coordinator of Health Information Technology, as Al mentioned. Their responsibility is to coordinate health IT across the country, to drive it forward, to manage all the different components of it, and be looking toward the future. So some of their key roles, defining the rules. What is health IT? What are the key components of those? And they've defined these as criteria. And for 2015, there are 60 criteria. And these are the components that make up health IT. The demographics, the exchange of information, all various components. At the end of this presentation, there are some links to some slide decks that ONC has put out. It's a very useful website, healthit.gov, and there's a great slide presentation that walks through the 2015 rule and pretty graphically, I don't know, that's the right way to say that, in graphic terms, explains what the rule means and outlines the criteria, how they fit together and stuff. And I think it's a very useful slide presentation that's on healthit.gov, and there's a link at the end of this presentation, so when the slides come out, you can use that. So again, what they do, they define the rules. What are the criteria? What are the key components that go into health IT across the board, not just an EHR, but what for your Fitbit and exchanging information from your Fitbit up to your health provider. In those criteria are standards. How is the data going to be managed? What is the vocabulary that you're going to be using? What are the code sets that are going to be using? All those are the key components that the ONC defines as part of the criteria. Second role of ONC is to certify these systems, to test them, to see that health IT systems out there do what they say they do. So they have created a testing mechanism using, they certify testing bodies called ATBs, OTBs, I can't remember what it is, testing bodies, certified testing bodies, who have created test plans for a system. Say it's to exchange information. Well, what does it mean to exchange information? How do you demonstrate it to me, and how do I certify it? And if it walks through this test correctly, they'll put it up on their website as a certified system. And you can certify for all of the criteria or some of the criteria. Well, enough about that. So a third part of ONC's role is to set the direction going forward for health IT in this country, to understand where we are today, looking at where we want healthcare to be. Is it going to save money? Is it going to be better for your health and stuff? And look toward the future. What are the technologies that we need to implement to drive this technology forward, to drive health IT forward? And there are many subcommittees that they have formed, advisory committees, I would say, privacy and security, standards, policies and procedures. These are large, major advisory committees advising ONC about the direction of where we're going to go. A final role for ONC today is to support health IT as it exists out there today. They can't just be looking to the future. So they're supporting electronic health records and health information exchange and meaningful use through grants, through their programs, and so forth. So I just hit this button. Okay. A little bit more background on ONC and CMS and meaningful use. Up until 2015, ONC and CMS were working together. Not that they're not working together now, but in the past, They worked closely together to define the rules for meaningful use. What are the measures that went into it? What are the criteria that go into it? And there was a focus mostly on outpatient and inpatient care settings. From 2015 and beyond, from this rule, this final rule, CMS and meaningful use have been decoupled from ONC. ONC is going to be setting the direction, defining the criteria, and providing the testing and all of that stuff. And other agencies, CMS, meaningful use, for example, are going to decide how to use those criteria in their program. So ONC is setting a menu. I have a menu, here's my lunch menu. You can choose, a small menu for your lunch, or you could have the banquet. And it would be the agencies that would choose those and certify their systems or their program, require that their program use technology that is certified to a certain rule. And finally, they are now creating criteria that support multiple settings. So they've added in criteria specifically for the behavioral health and long-term care settings. So I think I just said this, that the agencies and organizations will be defining the programs and how they use the criteria going forward. For example, CMS and other agencies, long-term care. It hasn't been defined who's going to decide what a long-term care system looks like, but there's work going on out there. Behavioral health and Department of Defense as well are using some of the criteria, that ONC has specified. Vendors are going to be the most impacted by these criteria because they're going to have to write systems that comply with these criteria. They're going to have to be able to test those systems in a lab for ONC, show them that it works, and see that it works out there in the wild as well. A couple of slides here about what the criteria, where am I from, huh? What the criteria are and how ONC is planning to use them. In 2015, ONC has defined a base EHR. What are the basic functions that an EHR, electronic health record, should have in order to be a useful system? Not for meaningful use. Meaningful use has decided to take this base EHR and add on about 16 other requirements to say, well, that's a certified EHR for CMS. But as far as ONC is going, they're saying this is what a basic EHR system should do. And there's going to be some major work for vendors when they get down to this API. It's going to be a lot of work for them to do to manage that, to get this information. That's going to be, I'll talk a little bit about that as we come along. And some other key ones, this implantable device list are new, tracking all your devices that are in, and direct project exchange here. Another key definitional set that ONC has put out there is this common clinical data set. What data belongs in an electronic health record? And can it be, it must be accessible and exchangeable to anybody or who certifies for it anyway. It's built off of the meaningful use data set from stage 2 plus new data elements. It includes, must comply with certain code sets and vocabulary standards, LOINC code, SNOMED, all of these at certain version levels so that people understand what the data is that's being exchanged. And basically it is the key data that can be exchanged or should be accessible about a patient regardless of where they are. And it, like I said, must conform to, there's some new criteria that were included in the 2015 rule that obviously weren't part of the 14 rule, and the key one is this application access to the common clinical data set, which is this API that we've been talking about. And it's going to mean some work for a lot of the vendors. Trusted connections is part of is required for this application access because you have to be able to trust the connection between them. Another one that's part of meaningful use that I think is going to be interesting is capturing patient health information and putting it up into the health record. I don't know exactly how that's going to happen, but these two down the bottom here are kind of basic requirements for all EHRs. Accessibility, that your website or whatever your application is, your EHR looks like, it must use accessibility design functions. I think you might have heard of Section 508 if you do any website design. You must, for people with disabilities or they have to be able to use your EHR the same as the rest of us. So there are font requirements, there are changes that you have to make. So those have to be built into your EHR. And I'm not exactly sure when it has to be used, 2018 maybe. But it means that your application, your EHR, must be able to accept requests for patient information, for patient selection. If I give it a name, date of birth, address, or something, it'll return an ID in your system. And then that ID can then be used to return patient category of information about the patient by category, for example, medications, or returning all patient data. It's going to be a lot of work for vendors to do this, and it's going to be, this would be accessible by a patient, this would be accessible by another vendor, this would be accessible by anybody who's given security access to it. And final slide here. These are some criteria that have been accepted as part of the 2015 rule that aren't really part of the meaningful use rule. They were designed for other settings of care, behavioral health, that your EHR should be able to have the social, psychological, and behavioral health data, and it must be accessible and exchangeable. Must be able to provide the summary of care record, so in transition of care from a hospital to a long-term care or a rehab, this information can be exchanged. Data segmentation for privacy means that even though somebody requests all data for a patient, you don't send them their HIV or their behavioral health data unless they have specific access signed off for consent to send that. So that's another major bit of work that's going to have to go into EHRs as we go along. The EHRs must be able to send one of the CDA documents that's called the care plan and exchange data with that. And then there are some changes to what you can do with quality measures, filtering on quality measures. I guess it's not the last slide. So this is a kind of a slide that shows how how the criteria get built up into an application. Down here, these are mandatory requirements. Like I said, you have to have a system that you can build the accessibility and the quality management. This is for the developers. It has to have a system that they can test and show that they've tested this system correctly. Those are the mandatory ones, and then there are conditional ones that, based on how your system is being built, privacy and security is different depending on the system. If it's a behavioral health system, it's a hospital system, or it's an outpatient system. Safety enhanced design, again, that for users of the system in the CDA creation. There's a whole bunch of documents in the CDA. You might only have to do 5 of them. And if you were a behavioral health, you're building a behavioral health system, these are some of the criteria areas of criteria that you're going to have to take into account to build your behavioral health system. And this probably should be alongside of this down here. If you had a long-term care, you'd have to take into account criteria in those sections to build your system. There are 60 criteria. There's a lot of criteria out there. And here, this is the final slide. And so, if you want to look at the rule, this is it. It's 590 pages long. I don't know. I've tried to read it. It's really a tough go. And one of these on here is the slide deck. And you know, if you want to find out more, healthit.gov. It's a great source of information about technology, what's going on, what the U.S. government and ONC and the HHS is pushing out for technology and where we're going. And I think that's my signal. And I'll be around the rest of the day too. I'll be sitting out here if you have any questions. Happy to answer them if I can about specific criteria or not.
Okay, thank you, Joe. We wanted to include that piece in on ONC and the technology, even though you're not software developers, but to show that connection between those requirements, specifications, and functionality, and where healthcare delivery is going. So all those points that Joe was mentioning that are built into the systems, obviously there are workflow and processes that are going to be reflected in the delivery of care that will utilize the health information technology. I want to just reiterate the work that we do at MeHI to help you navigate these waters. And this is the part that I'm involved with, the e-health services. Part of the mandate from the state is that we really provide services that are going to help people understand and be successful with health information technology. So we're working in the area of meaningful use and the attestation. This morning you heard from Tarsha Weaver, who oversees the whole e-health services, but one part is the actual review of applications for Medicaid, and then our part, which is outreach and services, more of a consulting arm. PQRS is something we've recently added, so those of you who are involved with the physician quality reporting system, we can provide support. The security risk assessment, we can provide support. And coming up soon, the merit-based incentive payment system, which is sort of the next chapter on how these various payment reforms are going to transition beyond meaningful use. There's contact information, and I'll turn it over to Liz to handle questions. And are you going to give all the answers, Liz?